Hey everyone and welcome. This is Medicine with Zaid. I'm Zaid. Today I'm going to talk about liver failure. So to understand liver failure, we have to understand exactly what the liver does and how we interpret investigations and how patients present with liver failure or liver injury. Liver injury is a term that I use for anything whereby there is an increase in their liver enzymes. So what are liver enzymes? Well, liver enzymes are things like ALT, ALP, AST, GGT. These biochemical markers, these are the things that go up when the liver is upset, i.e. when the liver's been injured or it's inflamed, okay? Now, inflammation obviously in itself can cause, some chronic damage and a bit of scarring. But a liver injury can be acute or it can be chronic progressive, relapsing, remitting. It depends on the disease. So, for example, if someone literally comes up to me and punches me in the liver, I'll probably get a slight ALT rise. If I have a cardiac arrest and the blood stops moving around my body, after a few minutes, undoubtedly, I will have an ischemic liver injury, okay? And I'll have an ALT more than 1,000. Liver injury could also be due to things like certain drugs. So certain drugs don't agree with the liver in certain people and they can have a liver injury with an ALT over 1,000. ALT over 1,000 isn't a specific thing, An ALT going up signifies that there's been some sort of damage or inflammation to the liver, but ALTs over 1,000 tend to point towards certain etiology. Those are drug-induced, viral causes, and ischemic causes. So if I have a patient who's come in, they've had an out-of-hospital cardiac arrest, we get return of spontaneous circulation, we do their blood, so they've got a troponin of, let's say, 300. They've got an ALT of 1,200, and they've got a kidney injury and reduced urine output. Now, that person has clearly got evidence of end organ damage. They've had a cardiac arrest, blood's not gone around their body, and certain organs have had an ischemic event. So, who knows how much of their brain will be working when they wake up, or if their kidney function will resolve completely. But I wouldn't be surprised if they had an ALT over 1,000. They've had an ischemic insult. So it's important when you're looking at things like ALT or even things like troponin to consider really what's going on, because someone coming in with cardiac chest pain and a troponin of 500 and ischemic features on an ECG, yeah, they're having myocardial ischemia, but is it because they've got fatty coronary arteries, or is it because they're actually in septic shock with a blood pressure of 50 over 30? So that's something really important. This is something that I think isn't really driven home when you're a medical student. The fact that massive ALTs or just like liver enzyme dysfunction where you get high ALT or AST or whatever it is, those don't really mean liver failure and they don't point to any specific etiology. And actually, it's the lower ALTs in otherwise well patients that are unexplained that kind of warrant more investigation to know what's going on there. It could be as simple as they just got a fatty liver from drinking alcohol every day, or they have diabetes or obesity. It could be as simple as that. Or it could be something quite insidious like autoimmune hepatitis or primary biliary cirrhosis, whereby there's a very slow, chronic, progressive destruction of their liver, which only shows up on liver enzymes and are otherwise asymptomatic until it's too late and a lot of their liver's been knackered with liver injury and now they need a liver transplant. But I digress. Let's go back to the basics. Liver injury, liver inflammation, and the term hepatitis, I want you to think of it all as the same thing. If I look at someone's bloods and I say they've got a bit of hepatitis going on, a bit of a liver injury, that's what that means. Something's happened to the liver. Is this something that has already happened and it's going to get better? Or is there a process that's still going on right now? That's what I want to know. So liver failure and liver injury. You can have a very injured liver and it not fail. And you can have, a liver with no acute injury that goes into failure, right? So these are two very different concepts. Now, progressive chronic liver damage and enough liver damage, acutely or chronically, i.e. you get a viral hepatitis and it's really, really bad and it wipes out loads of your liver quickly, or it could be from like decades of chronic alcohol use, okay? Either way, if you've got enough of your liver damaged, that can lead to chronic liver disease where you've got just enough liver function to keep you going, But every now and then something will precipitate decompensated liver failure, i.e. acute on chronic liver failure. This could be something as simple as a bit of bleeding, an infection, or it could be having another little binge and you just have an element of alcoholic hepatitis, and those working liver cells that are doing such a hard job, you know, because you've got so much liver damage and, you know, they're the last one standing. If you have an alcoholic binge and those working liver cells become inflamed, you could die from that liver failure. So, you know, chronic liver disease will present in a different way to, you know, liver disease due to acute problems. So acute liver failure, you know, you have to have something really, really severe happen to your liver to actually cause it to fail at that acute phase. You know, if you've got a healthy liver and you get severe acute liver failure, something really bad has happened and, you know, I'm pretty worried about you. So there's something called fulminant liver failure. I've seen it once in my career and I don't want to see it ever again. This gentleman came in, he was in his 50s, and in the space of 1 hour, he went from conscious and slightly confused to, I witnessed him just roll his eyes and his sats drop and he lost his airway. Luckily, I'd already involved ITU and I was trying to convince him of how sick he was. And they were saying he's fine and he's maintaining his own airway, and then we saw that happen before our eyes. That patient actually died that night of a massive GI bleed from acute liver failure. So fulminant liver failure, that tends to be in massive, you know, liver toxic drug overdoses such as paracetamol and viral hepatitis. It's unusual for people to die of an ischemic liver failure from fulminant hepatitis because they would have had enough end organ damage everywhere to have just died. And fulminant hepatitis is a process whereby an illness has caused the liver to just go straight into apoptosis rather than go through the whole inflammatory process. That's not common, but it's worth a mention. The traditional liver function test that you will click to order in your hospital, you will get back an ALT, a bilirubin, an ALP, and depending on the trust, some other things, sometimes an albumin or an AST or a GGT. Now, liver function tests, okay, those are tests that describe someone's liver function. Now, ALT tells us nothing about the functioning of the liver. It just tells us that there's been an insult, inflammation, or injury to the liver. And the same goes for GGT, ALP, AST. Now, ALT is the most specific to the liver, okay? You would then use things like a gamma GT or an ALP or an AST to sort of narrow it down. If someone has a high ALP, for example, that's broadly due to things like a cholestatic problem, whereby there's an obstruction of bile. That could be due to a gallstone or a cancer, for example. ALP can also go up if there is hemolysis or bony lysis. That can also cause a rise in ALP. So if you have a patient presenting with a high ALP and you do some imaging of their abdomen and there isn't any problems with the hepato-pancreatic biliary tree, then you're wondering what's the cause of this ALP. Now, if the ALT is also raised, then you're thinking this is probably just a hepatitis, a liver inflammation, right? But if the ALT isn't particularly raised, then you have to think, well, there's no, problem with the, biliary tract, then maybe it's blood or bone. So if you're thinking blood and bone, you're thinking hemolysis and you're thinking in particular bony mets, for example. For hemolysis specifically, I would get an LDH and a Coombs or a DAT, a direct antiglobulin test, and I'd look at their HB and have a think about that. So that's ALP. ALP is something that points to not a specific etiology, but a certain set of etiologies of problem. If you have a patient who's got a high ALP, the gamma GT can be useful in telling you if this is a liver pathology or pathology somewhere else. So if they have a high gamma GT, you think that ALP is related to the liver, the hepatobiliary system. But if it's not raised, then you're thinking maybe blood or bone or something like that. Gamma GT, however, it can be non-specific, and the same goes for AST. You can look at the AST, the ALT ratio, and it may point towards certain etiologies, but they're very non-specific and not very sensitive. So AST is not used a great deal. Gamma GT, again, not used a great deal. I think gamma GT is useful when you have a patient with a high ALP and there isn't a clear or obvious course. So those are your liver enzymes: ALT, ALP, AST, gamma GT. So what do I define as liver function tests? Well, before we talk about liver function tests, let's talk about what the liver actually does. So very broadly speaking, there are two main functions of the liver. I split them up into synthetic liver function and metabolic function, okay? So the metabolic function, that includes elimination and processing of toxins. So the liver is supplied by the hepatic artery and the portal vein. The portal vein carries blood rich with nutrients from the digestive tract, and it all gets metabolized in the liver. Blood also leaves the liver through the hepatic vein. The liver also has lots of biliary tracts, and that will basically collect in the common bile ducts and either get stored up in the gallbladder or go into the digestive tract. The liver also gets rid of toxins. So for example, ammonia. If you have liver failure, your liver can't get rid of the ammonia goes to the brain and it causes delirium, more specifically what we call hepatic encephalopathy. If you leave a patient with hepatic encephalopathy with high ammonia levels for too long, lying down in particular, they can get cerebral edema. So you don't want ammonia hanging around in your blood, and your liver gets rid of it. But it gets rid of a lot of toxins, a lot of products from the digestion, alcohol metabolism, and importantly drug metabolism. And that's why certain drugs can cause liver failure. If they cause a bad enough liver injury and it gets so inflamed, there's not enough working healthy liver to do the job of what it's supposed to do. So yeah, the liver is also responsible for metabolism of blood. So it breaks down blood and it goes through that whole bilirubin, bile production. I'm not going to go into that now. It's also got a role in the metabolism of glucose. So glycogenolysis, so the breakdown of glycogen into glucose. And also if you have low stores of glucose or glycogen, then it can also form glucose through the process of gluconeogenesis. So patients with liver failure, they can also go hypoglycemic, and it's one of the common causes of them deteriorating and cardiac arrest calls. Hypoglycemia is something that we often miss. If they're not eating and drinking well because they're alcoholic, if their liver isn't able to produce glucagon and it's not able to perform gluconeogenesis, then you can go hypo and die. So the second, broadly speaking, function that it does is synthesis. So it makes stuff. Importantly, it makes protein, notably albumin, and it makes clotting factors. So patients with liver failure, they may not make albumin, and therefore they have less albumin in their bloodstream, less oncotic pressure in their bloodstream, and water can seep out from the intravascular space into the extravascular space and make you edematous. And because you have a lack of albumin, you're not going to have a very good blood pressure, and you just get swollen. Albumin is also important because it allows the carriage of many things, including lipids and clotting factors and immunoglobulins. All sorts of things are attached to that albumin, so it can cause a whole host of problems. The liver is responsible for synthesizing hormones, especially like for erythropoiesis, and it's important for synthesizing these clotting factors, as I mentioned. So a patient with liver failure, they may have bleeding for many reasons, one of them being portal hypertension and variceal bleeding, but they will be in a more bleedy state, okay? They may have an elevated prothrombin time and INR, and they are more prone to bleeding out. Most patients with an acute liver injury won't have liver failure. It's only those severe cases I'm talking about, or if they have pre-existing chronic liver disease and a lot of their liver is already knackered. So now we've talked about liver function and we talked a bit about liver failure, we can understand a bit more about liver function tests. So let's go back to liver function tests and talk about them. I would define liver function test not as your lab calls it when you request it, but liver function is the synthetic function. So I want to know that bilirubin, because that's telling me about the function of the liver. Is it able to metabolize blood correctly? Okay, so their bilirubin level. If their bilirubin isn't high, I don't think it's liver failure. It wouldn't make sense for it to fail doing other things, but not that. And again, the same goes for the other parts. So do they have a coagulopathy? Is their INR or their prothrombin time raised? Okay. Do they have a low albumin? Now remember, albumin is an acute phase reactant. You can have sepsis, for example, or nephrotic syndrome, or just proteinuria. A low albumin isn't necessarily due to liver failure, but if you have a patient who's got a liver failure for more than several days, you'd expect their albumin level to be low. So I wouldn't say a normal albumin level rules it out at all. But it's something to look at, particularly in patients with chronic or acute and chronic liver disease. So we also want to look at their ammonia, and ammonia is important. It's not the most specific test, but you know, if you've got a patient who's drowsy and you're worried that they could have liver failure because they have evidence of liver injury and you're struggling to find another reason for them being confused or drowsy, for example, you know, an ammonia can be helpful. When you do take an ammonia, it should be taken immediately to the lab and ideally on ice. So a patient with chronic liver disease due to, let's say, alcohol, if they present and they have a normal ALT, but their INR is 1.5, their albumin is 22 and their bilirubin is 75, yeah, they haven't got liver injury, but they're in decompensated liver failure, I suspect. On examination, they may be a bit jaundiced. They may have some ascites, some peripheral edema. They may be a bit icteric, a bit drowsy, for example. That's what you want to look out for. So I've talked about liver enzymes and I've talked about liver function tests, but what other tests are there? Well, I want you to think of it like this, okay? There's 3 questions, that's 4 fingers. There's 3 questions that I would ask and then expect certain investigations as the answers for, okay? So my first question, has there been a liver injury? Has there been an insult? Has something happened to the liver? Do I need to worry about the liver, okay? If I'm asking that question, I want to know liver enzymes. My next question is okay, so they've got a liver injury, but is their liver working, or is there enough functioning liver to maintain them well at the moment, okay? So what is their liver function, okay? That's what I'm finding out from liver function. You know, they may or may not have a liver injury. I may be suspecting that they've got a chronic liver disease which is undiagnosed, for example, and they may not even have a liver injury on their ALT, for example. I may want to know their liver function. I want to know, is their liver working right here, right now? You know, it doesn't matter. It won't tell me if it's acute or chronic necessarily. It will just tell me, do I need to worry about liver failure? Do I need to worry about hepatic encephalopathy? Do I need to talk to ITU? Do I need to look for the cause of this? The third question I want to be answering is, okay, I think they've got a liver injury or I think they've got liver failure. I want to know the etiology of this liver problem. What is the cause of this liver injury or this liver failure? Now, usually I'm asking the cause of what has caused the liver damage to lead to liver failure, okay? So, you know, someone presenting with chronic liver disease, you know, it may be obvious, and often diagnosing a chronic liver disease or a liver problem is clinical, and sometimes we do need to do a biopsy or specific imaging to back that up. But generally speaking, the diagnostic stuff is for patients whereby there is a reversible or treatable cause that you want to make sure you've excluded, okay? So, you know, a 50-year-old lady who's obese with diabetes with a fatty liver, 100%, you know, that looks like a non-alcoholic fatty liver disease. I shouldn't exclude that she hasn't got an autoimmune hepatitis or primary biliary cirrhosis on the basis that, well, she's obese and she's got diabetes, it's non-alcoholic fatty liver disease. Because if she did have an autoimmune hepatitis or primary biliary cirrhosis, we would never know unless we do the blood test. So there is a time and place to do the full diagnostic tests, but you need to be specific, okay? I don't think it's right that you have a patient with an ALT over 1,000 and without thinking about why it's over 1,000, you know, they had septic shock yesterday, you just go and order all the tests because someone needs to interpret that and work out what's going on, and half the time it's just inappropriate. Do I think this young, fit 20-year-old who's just contracted, you know, infectious mono, do I really think that they need a full liver workup? Or should I just repeat the liver function tests, the liver enzymes, in a few weeks and see if they actually need any investigations or if it was just the Epstein-Barr virus that caused it? I hope you follow. So these diagnostic tests, what do they involve? Well, there's the bloods, and then there's the imaging, and then there's the biopsy. Okay, so imaging is important. You know, if someone is acutely unwell with jaundice, they need to have an ultrasound, end of story. You need to make sure that there's no biliary cause, no obstructive cause, no obvious malignancy that's there. And you need to also see if there's any obvious fatty infiltration. You know, if they're coming with an acute liver injury, I want to know, have they actually had a chronic progressive liver injury for months and months and now it's got suddenly worse? Is there a disease going on that I don't know about? You know, it can also tell me if they've got a blood clot obstructing the you know, hepatic artery from a Budd-Chiari, for example, you know, an obvious cancer. The ultrasound will also tell me if they've got any clinically observable ascites that may be worthwhile doing a diagnostic tap to see if it's translate or an X-state or if there's any infection there. CT scan is useful, particularly if you suspect that there is a malignancy. If the patient comes in acutely unwell or overnight, for example, you don't have access to ultrasound and you're just worried about them, you don't know if there is a infection there or an abscess or an obstruction, for example, and you just need to get to the bottom of what's going on, you know, a CT scan may be appropriate. And then you get your MRI, so an MRCP. MRI is more of a specialist thing to request, and it tends to be to look for malignancy or to identify where the source of the malignancy is, but it can be used for lots of things, and it looks at the biliary tract in more detail. I'm not going to talk about the indications here. When it comes to bloods, you know, we've got our ANA, AMA, ANCA, you know, things like that for autoimmune causes like PBC, PSC, autoimmune hepatitis. And then you get your metabolic causes like your Wilson's, your hemochromatosis. So you'd want to do a chiraloplasmin, you know, iron studies, stuff like that. You know, if I've got someone who's in their 40s and they're coming in and they're a bit ataxic and they've got features of Parkinsonism, I'm thinking Wilson's. But if it's a 70-year-old who isn't ataxic and they're not walking funny, and, you know, there's no family history of it, and, you know, they just got a bit of a liver injury, do I need to order it for them? Probably not. So just think about what you're doing when you're ordering these tests. And the other thing is a viral screen. Okay, so is this acute hepatitis B or C or something like that? Is this Epstein-Barr virus? Is it CMV? Is it HIV? Could it be a parasitic thing, for example? Could it be related to malaria? Could it be a, you know, there's so many causes, but you know, I don't think you need to do a parasite count on everyone. I think you just need to have an understanding of a lot of these diagnoses and a lot of these investigations, and just be appropriate when you're ordering all of these expensive blood tests, because half the time I think we're just doing it blind, need to tick a box, and we don't need to do that, and it can cause confusion later down the line. So let's talk more specifically about the causes of liver failure. I divide them up into acute, chronic, progressive causes. So acute causes, you've got an ischemic insult, okay? There has been a lack of circulating oxygenated blood, okay? There's been septic shock, cardiogenic shock, cardiac arrest, you know, anything like that. And then you've got your viral hepatitis, not very common, but they happen. Your drug-related causes, now they're really common. There's so many drugs that causes. Paracetamol overdose can cause it, but things like nitrofurantoin, you know, amiodarone, methotrexate, there are lots of drug causes, and I'll put some of them here now for you to see. But always think about drug-induced and take a history related to drugs and things that take over the counter, as that may give clue. And then you've got alcohol-related hepatitis, you know, that's just part of the drug-related causes if you think about it. Then you've got causes related to obstruction, like a biliary obstruction. Now, it tends not to cause liver failure, but if it causes a bad enough liver injury, they could go into failure, so I thought I'd mention it. Then we've got our chronic causes. Now, the chronic causes tend to be chronic progressive, and they make up things from, you know, chronic alcohol excess, being obese, type 2 diabetes. Those are the commonest causes, basically. But then you get your rarer causes, so think of it in a surgical sieve way, okay? So the mnemonic is vitamin C. For vascular causes, I want you to think of it like blood going into the liver and blood going out. So not enough blood going in, that could be slowly getting worse from a Budd-Chiari or from a shunt, or it could be, you know, acute from, you know, acute hemodynamic instability. And then problems with blood coming out. So is there actually heart failure and there's congestion of blood going into the liver causing a backup? I for infection, so is it a viral hepatitis? Is there an abscess there? Is it parasitic? You know, did they have HIV? T for trauma, someone punched them in the liver. Have they had a, you know, road traffic accident, for example? A for autoimmune, so is it an autoimmune hepatitis? You know, is it a primary sclerosing cholangitis, primary biliary cirrhosis? Metabolic causes, so is it due to hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, for example? Metabolic, like more congenital causes like Gauchers and Fabry's, that's a bit out there, I wouldn't expect you to get that. But yeah, VITAMI for inflammatory. I for iatrogenic, is it related to they've just had an ERCP, for example, or they've just had some sort of liver damage from surgery? I don't know. And then N for neoplastic. Is this a HCC? Is it a cholangiocarcinoma? Is it liver mets, which are surprisingly common with disseminated cancer? So how do you manage someone with an acute liver injury? Well, firstly, you want to know, are they in liver failure? Now, if they're not jaundiced, they're not confused, they're not, they seem all right, their bloods don't point towards it, then they haven't got liver failure, and I wouldn't worry about it. But what you just need to establish is this an explained cause of hepatitis? And if it isn't, what investigations do they need? Okay, so that may involve the imaging or the biochemical tests. If you establish that they do have a liver failure, then you need to manage them as a liver failure patient. Now, liver failure is a big deal, okay? This could be your first episode of liver failure from years of alcoholism, and this could be your first presentation, and you could die. You could die, like anyone who's got an acute liver failure, be it acute or acute and chronic, we should be talking about escalation status. We should be making, CPR decisions early on. We should be involving ITU and a gastro team and any specialist liver input from tertiary centres at the earliest possible convenience for the sake of this patient's life. Now, there is obvious things that you can do to help someone with liver failure, but there are things that you need to look out for, and you need to find these problems and treat them before they get worse. So the biggest thing with liver failure is infection, bleeding, and encephalopathy. So hepatic encephalopathy is where you get too much ammonia to go to your brain, and you can check the ammonia in the blood. Now, hepatic encephalopathy is a big deal because it can make you delirious. And if you're delirious, you may not eat and drink, you may not comply with treatments, you may fall out of bed. You may become so encephalopathic from it that you become drowsy, and when you eat and drink you aspirate, you choke, for example. Or you could be so drowsy that you lose your airway and you stop breathing, or you get your respiratory failure. So that's why hepatic encephalopathy is a big deal. If you leave a patient lying down flat for too long with hepatic encephalopathy, they can also get cerebral edema, and it's a bit too late by that point. So the first thing I do is make sure these patients are sat up at 45 degrees, and we throw everything at them to reduce hepatic encephalopathy. So rifaximin, that's a drug we use mainly to prevent it and act prophylactically, but we've got rifaximin. Lactulose. Now, lactulose, it helps to absorb some of the ammonia in your blood, and it's a laxative. Now, lactulose isn't a very good laxative. You need to drink 2-3 litres of water a day just to make it work, and patients with liver failure should be on a fluid restriction. So lactulose you should give. I like to give up to about 120 mils spread out over 2-3 times in a day. And the lactulose is really helpful for hepatic encephalopathy in absorbing some of the ammonia. But you don't want to use just lactulose. You want to be aiming for them to be opening their bowels 1 or 2 times a day, ideally 2. So that means you need to give them lots of Movicol. Okay, you need to give them proper laxatives that are evidence proven, like Movicol, for example, or should I say compound macrogol solution. You want to give that and make them poo. And if they haven't pooed despite your laxatives, give them an enema. Because the more poo you clear out, the more ammonia you get rid of, the more movement of ammonia out of the blood into the digestive tract. So sit at 45 degrees, give them laxatives, consider giving them rifaximin as well. And obviously you want to make them nil by mouth if you think that they're drowsy enough to have a risk of aspiration. Now, unless you're trained to do a swallow assessment, that's a very clinical decision, okay? I sometimes get a patient have a very small sip of, some nice clean water and just see if there's any obvious or overt aspiration. If there is, you don't need to worry about it. Nil by mouth, put an NG tube down for feeding and meds, assuming it's appropriate and they're not, for end-of-life care, for example. And get your SALT team and your dietitians to see them and go from there. The thing is, hepatic encephalopathy, it goes up and down, and it can get better and can get worse. And assuming that right now the patient seems to be eating safely and fine, I wouldn't assume that it'll be the same tonight. So you have to have a low threshold to make them nil by mouth and put an NG tube down, because aspirating from being drowsy from liver failure, I think it's a failure if you haven't made that decision. The next thing on the topic of nutrition, you should get a dietitian to see them, because they may be malnourished if they're alcoholics, for example. But from a nutritional perspective, acutely, like managing this sick, unwell liver patient, check their blood sugar. Okay, a lot of these patients, you know, especially if they're not eating and drinking well at home, they will come in hypoglycemic, and they will develop hypoglycemia when they're under stress. You know, their liver may not have the function to do gluconeogenesis, they may not, you know, make glucagon, and you can find them with low blood sugars. And I've run to many medical emergency for liver patients with low blood sugars. And, you know, remember, when they've been hypoglycemic for a certain amount of time, the end organ damage, you've kind of lost that battle, and that patient probably needs to be palliated at that point. So don't ever forget to do regular blood sugar monitoring and making sure if they're not eating that you're checking it. Since we're talking about nutrition, I'll quickly get it out of the way. Always check B12, folate, and consider putting up a bag of Pabrinex, you know, if they're alcoholics in particular, or if they have been malnourished at home. The dietitians can help you with that, but if they're an alcoholic, just stick them on 2 pairs 3 times a day and treat them as though they got a Wernicke's encephalopathy just in case. Make sure you don't give them any drugs that are metabolized by the liver in big doses. You know, just be cautious with things like that, and be cautious giving them things that will suppress their CNS. You know, benzos and opiates. You know, you have to be, you know, cautious not to make things worse with their drowsiness. And, you know, you have to be careful using things like paracetamol, if at all. You'd also want to be cautious giving them any drugs that will exacerbate certain things. So, for example, patients with liver failure are more prone to going into kidney failure due to hepatorenal syndrome. So you want to hold off on nephrotoxics, for example. Definitely avoid NSAIDs, okay, unless you have a death wish for your patient. And if they do have any evidence of bleeding, i.e. rectal bleeding or hematemesis or a very high urea and a low HB, make sure you correct any coagulopathy. So INRs more than 1.5, you would want to correct that with some prothrombin complex or FFP. Those sorts of things you would usually discuss with the liver team, and they would give you advice, although then guidance on the British Society of Gastroenterology website. But yes, you would want to correct it with vitamin K, potentially you'd want to give some tranexamic acid, and yeah, aim for an INR less than 1.5, and if they have low platelets and they're bleeding, then you would also want to consider giving them platelets. It's quite difficult when you've got a very fluid overload liver failure patient giving all of these things, so you just have to, you know, be strategic on how you give certain blood products and certain drugs or whatever it is when you're, you know, dealing with them when it comes to their fluid balance, because they usually have a low albumin, and there can be a role for albumin solution in these patients, but that's quite specific, and it's more when they're intravascularly dry and extravascularly overloaded, and their albumin, you know, can be topped up in certain scenarios, you know, if we're draining ascites from their abdomen in particular. If you do think that your patient has GI bleeding, talk to gastro, get an OGD, get the gastroscopy done sooner than later. You know, you'd want to do a Glasgow Blatchford score just to see how worried you are about this bleeding, if there is bleeding. And it will also, you know, put the, you know, it will also inform the gastro team of how sick your patient is. And, you know, that's really important for your notes. You know, if your patient deteriorates waiting for an OGD, whose fault is it that the patient was waiting? Is it your fault when you identified it, or is it the service's fault? I'm not blaming specific gastroenterologists, but some hospitals don't have a very good OGD service out of hours, for example, and, you know, these things can be relevant. Goes without saying, if they're GI bleeding, 2 large bore cannulas, you know, prioritize giving them blood products. Make sure you do a group and save or a cross match. Do a PR to confirm if there is melena, if you're suspecting bleeding but haven't seen it yet. Make sure you hold any antiplatelets or anticoagulants they may be on, and make sure you correct their coagulopathy. Never ever ever assess the severity of someone's GI bleeding based on their HB, okay? That is not how it works. A patient with an HB of 100, let's say they just hemorrhage before my eyes 2 litres of blood. I can check their HB again and it will be 100. The concentration of the blood has not changed, it's the volume of the blood that's changed. The blood will obviously become more dilute over the next few hours or days as the body starts to retain more fluid, more water, to try and maintain that intravascular volume and keep your organs perfused. But until that happens, their HB will be normal. So who is it that I put out the emergency call for, that I put out the massive hemorrhage protocol out for? It's not to do with HB, although a low HB and, you know, features of severe bleeding will also worry me. What worries me is persistently low or refractory blood pressure, i.e. they've got low blood pressure, but despite giving fluids and bloods, it's still low. And the patient who gets dizzy when they're sitting up or when they're standing, okay? Don't worry about the blood pressure. There are different stages of shock, and they may be compensating for their low blood pressure right now with their massive blood loss, but sitting up or standing up is just a bit too much. They've already constricted everything enough, and they just can't perfuse their brain properly when they stand up because everything is at its limit, okay? So if you've got a patient who comes in with syncope from bleeding, or they feel pre-syncopal, or you need to lie them down for them to feel like they're not getting dizzy, those are the patients who you need to worry. You need to run, you need to get the blood, you need to push it, and you need to get this patient in for a scope as soon as possible. Ideally when they're stable in the next few hours, but remember, with GI bleeding, they may not stabilize for you. You may need to get the OGD done with them being incredibly unstable because it may be the only thing that saves their life. And that is something that occasionally has to happen up in ITU or in resus. So that's liver failure in a nutshell. Liver failure patients are prone to bleeding. They're also prone to blood clots. So, you know, if there isn't any bleeding, they should be on prophylactic anticoagulation. They're also prone to infections. They're prone to becoming fluid overload from hypoalbuminemia. They're prone to being malnourished. They're prone to becoming hypoglycemic. They're prone to becoming drowsy and encephalopathic and losing their airway and having respiratory failure or aspiration, etc. They're prone to dying. They're prone to multi-organ failure. Involve ITU early. Talk to the specialist liver team early. Identify and reverse any cause that is precipitating it or making it worse. Give them NAC if it's a paracetamol overdose. You know, if they've got drug-induced hepatitis, stop any potential drug. You know, that nitrofurantoin that they've been taking for a urine infection over the past few days, it could be killing them. If they go into renal failure, think about hepatorenal failure early. You know, that will require terlipressin, that will require potentially, you know, albumin, renal involvement, ITU. Don't forget about rarer causes of hepatic encephalopathy. You can have a patient who doesn't have any features of liver failure biochemically, but they have a hepatic encephalopathy. The only way you would find that out is by doing an ammonia level. It's quite rare, but I've seen it once in a patient who had a liver transplant. And essentially, because they have a liver transplant, the vascular anatomy of the liver isn't the same. And slowly, chronically, progressively, they developed a portosystemic shunt, which caused ammonia-rich blood to go straight to the brain without a chance to go into the liver to be processed and have the ammonia eliminated. So this patient had, you know, lumbar punctures and all sorts of tests looking for the cause of their low GCS. Now, we did do an ammonia level when they first came in, and we suspected liver failure, but it just didn't make any sense biochemically. And we spoke to the liver team, and again, they weren't overly concerned about liver failure, as ammonia is quite non-specific. But it was only after excluding all the other diagnoses and looking back at the imaging that we found this shunt. That's liver failure in a nutshell. Go out there, start thinking about your patient's liver enzymes, their liver functions, and, you know, think about those, you know, women, for example, in their 40s with unexplained transaminitises or, you know, liver enzyme problems, because they could have something going on, and that ANA or AMA test you do could just save their lives, save, you know, 20 years of their life for all they know. Thank you for listening. If you found this helpful, please hit like, hit subscribe, share the video, help support my page, because I love to teach. I love to teach because I think I'm good at it, and it also gives me an excuse to go back to the books, understand it a bit better myself. And I like to think I've got a good way of explaining things and sort of understanding why people don't understand certain topics, because I was that medical student who didn't know what was going on in lectures and went home and learnt it, but maybe learnt it in my own way that didn't necessarily correlate with real life. And that's what I'm trying to do for you here today. So like, share, subscribe, all that stuff if you found it helpful. Leave a comment and give me any feedback you want to do. And until next time, stay safe. Peace.